Welcome back to Taking Charge of My Cancer podcast, episode 55. Joining me today is Dr. Carroll, Brett Carroll. He is the director of the section of vascular medicine at Beth Israel Deaconess Medical Center and an assistant professor of medicine at Harvard Medical School. He completed his internal medicine resident at Massachusetts General Hospital, general cardiology fellowship at Beth Israel, and vascular medicine fellowship at Brigham and Women's Hospital. He's also the director of lymphatic medicine and see over 300 patients annually with lymphedema as part of the BIDMC, Multidisciplinary Lymphatic Center, with the primary role of appropriate diagnosis and conservative management of lymph swelling. Dr. Carroll is also the medical director of the Beth Israel Deaconess Aortic Center and the director of the MASCOT and BIDMC Multidisciplinary Peer Response Team. His research interests include venous thromboembolism, aortic disease, and lymphedema. So Dr. Carroll, thank you so much for being with me tonight.
No, thank you. It's a pleasure to be here.
Absolutely. So you want to tell us a little bit about your mission? Like, how do you end up doing lymphedema?
Yeah, it's a good question because there's not many of us out there that focus on lymphedema from a medical perspective. So I had a little bit of a circuitous path to it. I had always had a passion once I started medical school for cardiology and kind of the functional role of the heart that's constantly beating and its interaction with blood vessels. And then as I got into fellowship, had a growing interest in blood clots and disruption of blood flow, whether in the arteries or the veins. And the lymphatics are a very important aspect of blood flow, though has been traditionally quite ignored, both in medical school and really in clinical practice. So when I did my vascular medicine training, which was really my focus on the blood vessels after cardiology, I saw some patients with lymphedema, but it wasn't really until I came back on as faculty at Beth Israel and joined Dr. Drew Singal, who's a plastic and microsurgeon with a particular interest in expertise in lymphatics, where we started to work a little bit together, and it really took off and work as a great team, learned a lot from each other, and really his experience. We started initially to work together, would see patients clinically together, and then with the growth of a multidisciplinary team, really kind of changed the way we function. And now we see most of the lymphatic patients up front, myself and our nurse practitioner, Betsy Rose, and then help guide patients in optimizing conservative management for lymphedema and work closely with our radiology and surgical colleagues. So it was really that interaction with Drew where we saw this unmet need, and he was seeing a lot of patients that didn't need or weren't appropriate for lymphatic surgery. And we had the appropriate kind of knowledge and skills from a medical standpoint to help manage them conservatively in close conjunction with our lymphatic therapists. So that's kind of where it took off. I'll say it was a lot of self-learning and reading and just experience over the years, because there's not a lot of places to go to learn about lymphedema.
Yeah.
Like I said, in medical school, we learned, maybe 15 minutes about it and kind of skipped over. So we're learning more and more about it. And I kind of came into it with eyes wide open and learned a lot from Drew and really our patients.
That's amazing. And it's such a need. It is, I'm in Gainesville in Florida, and UF healthcare system, and even here and many other places, and I'm sure you have heard this many times, how it's not a physician who knows how to diagnose lymphedema, right? So we find somebody that perhaps, I do a lot of oncology, so it's more lymphedema from the oncologist standpoint, not necessarily primary lymphedema, but I can have a patient who perhaps has some primary lymphedema, and they're like, you need to go back to your doctor, but I don't have anybody who, like you, like I can say, you need to go see this vascular physician who knows what lymphedema is. Just go to your primary care. And they're like, well, I've been there many times and nothing really has been done about it. So it's such a huge need that I'm so glad to have somebody like you. I hope that you'll have multiple clones of you, right? In every direction, because it is a huge need from the medical standpoint for somebody to really know what lymphedema is and how to diagnose and then send those patients in the right path, right?
Yeah, no, I think it is important to have at least an initial evaluation to help kind of guide patients in the right direction. And it is, being a chronic disease, it's a big diagnosis to be made. And we always say when patients come into our clinic that even if they've been diagnosed with lymphedema or think they have lymphedema, we say, you're coming in clean. We're going to look at you and make sure that there's nothing else that could be leading to your swelling as well, because there are other things that we could potentially treat in different ways. So even if a patient's been treated for a decade or two with lymphedema, we really try to come in with a fresh set of eyes and make sure there's nothing else that could be contributing. And if it is lymphedema, talking about what that means for the long-term prognosis and how to help manage it. And there is no cure. So, how do we maintain it and try to improve it and improve quality of life? Because there isn't a pill that we can just give, unfortunately. But I think to your point, there aren't a lot of physicians, but it is growing. I think the vascular medicine world is increasing, and it's been traditionally managed by lymphatic therapists, which have done, a wonderful job, but, have their limitations in terms of, ordering imaging or other things that may be additive on top of the therapy itself. And plastic surgeons, have their role for sure, and have traditionally been one of the go-tos because they can do some of the surgeries, but even that is limited at this point. So I think trying to seek out some individuals that have a little bit of expertise and experience can be helpful, just even to define the diagnosis and make sure you're dealing with what you think you're dealing with.
Yeah, that's exactly what we do. So many times, if I'm suspicious of it, we will say like, no, let's go to cardiology, right? Let's just, the first thing, right? Is this not coming from the heart, right? Is this coming from the kidney? Let's kind of see what swelling can come from. Unless at least we rule that out, which is the same ruling out that we do. If we have somebody with lymphedema before we do any treatment and they have any history, we got to clear that out, right? We got to make sure that we are going to be okay to bring all that amount of fluid into the heart, and we don't put them into congestive heart failure from lymphedema treatment. So sometimes we got to be careful as well as a physical therapist, right? To see like, yes, we with all the heart, we want to help these patients, but we need to make sure that these patients are clinically okay before we can even start any treatment on them. So that's really important.
Yeah, completely agree. You have the patient that is clearly breast cancer related. Those are, a little bit more straightforward, but we'll occasionally get the patient that, also has a pacemaker on that side or had a history of DVT, and we can work through, is there a venous issue? But the upper extremity tends to be a little bit more straightforward. But I completely agree, for the lower extremity, particularly the bilateral lower extremity where both legs are involved, have to step back and say, is there anything medical that we're missing before we just focus on the lymphedema? Often lymphedema is a large component, or maybe the only component, but could there be, to your point, a heart process or a kidney process or liver process that's driving a lot of that fluid? And one, you don't want to make them worse by decongesting them, but also there could be a very different management approach if there an alternative is identified.
Exactly. So if you have 3 valuable tips that you learn about your journey working with lymphedema patients, what that will be that you think will be a value for the audience?
That's a good question. I think there's a few. So I think trying to work with them in understanding that it is a chronic illness and that it's not going to go away fully, but that it can be managed and maintained and improved. We see a lot of disease states that, we say, take this pill and your cholesterol will go down, or your blood pressure will go down, or your blood clot won't come back. Unfortunately, we don't have that for lymphedema. So trying to work with the patient and help them understand, and it's not easy. It doesn't necessarily happen over one visit. It may take months or years for them to fully grasp it, but it is really a patient-driven management strategy, and we can help and therapists can help, but the day-to-day time that it takes to really manage lymphedema is a lot, but it can be done if the patient is willing to put the time and effort in. So it's certainly not easy. And I'm not trying to minimize what they have to go through, but working with them to understand that, because I think we have some patients that come in that are looking for the quick fix, or, I had cancer and they removed it and they got rid of it, or I did radiation or chemotherapy and it went away. Why can't you fix my lymphedema? And unfortunately, we're just not there. Even with some of the surgeries that are available, they're not perfect and not a cure. So I think trying to work with the patient, trying to understand that a little bit. And once they can accept that and take ownership over the disease themselves, they tend to do a little bit better. I think some of our patients that are managed the best are the ones that are super diligent in understanding their limb and how to control it and working with their therapist closely and not being dependent on someone else to do it. Because unfortunately, that's just not going to work because it's such it requires day-to-day need. I think additionally, understanding the importance of exercise and weight management, particularly for lower extremity edema. We know for breast cancer-related lymphedema, it's higher risk after getting breast cancer treatment that if a patient is overweight or obese, that the risk of developing lymphedema is higher. And certainly weight loss and exercise can help with upper extremity lymphedema, but it can really be a game changer for those with lower extremity edema. For those with the more extreme weights, that can even be the main driver of the lymphedema. We see patients that are like borderline cured with weight loss. And then it can be a large contributor for those that may have, for example, a prior, cervical cancer, and they have lymphedema that's secondary, but the obesity is just making the lymphatics work even harder, and it's very difficult, to give a second hit on top of the initial insult to the lymphatics. And so managing the weight, and again, appreciating it's not easy and it takes months to years to do that. There are some new medications that can be helpful to kind of jumpstart it. And then just general, exercise activity. And I think finally it's a little bit of a misconception that compression is the end all be all. It is essential without a doubt to good lymphatic management. But in patients that have a lot of edema, I don't think it's well understood by most patients and definitely by most physicians that lymphedema is unique in that it causes fat deposition. So a large component of increased limb girth can be fat tissue. And it's got nothing to do with diet or exercise, though, again, those are very important. It's a local process in the limb, and that can drive increased girths. So patients that are wearing compression say it's just not helping. It may be that it's doing its job, but that you can't move the fat, you can't compress further. And in those that have a lot of edema, so have a lot of pitting, so you push in with your thumb and you can leave a mark, that is the fluid on top of the fat deposition. Those patients, though, compression is very important to help maintain. It's not going to generally get rid of that fluid. So getting hooked up with a very experienced therapist that can do complete decongestive therapy and a course of wrapping for a couple weeks or whatever it may be to really squeeze out that fluid, and then getting into a well-fitted garment, flatten it or off the shelf, but often flatten it to help control that benefit. I think, unfortunately, that's not sought out enough. And it's not the patient's fault, but they're seeing a therapist that may have some experience, but not a ton of experience with lymphedema, is not sure how to do it. But I think we unfortunately see too many patients that are poorly controlled because they just don't have the right fitting garment. But even if they do, they never underwent a course of decongestion to decrease that fluid component and then get the compression to maintain. So I think those kind of three of, understanding the chronicity and the self need to kind of maintain it, the exercise and weight loss being such an important component, and then the trial of decongestive therapy, especially initially, or even some patients annually, to kind of get a tune-up and then get into compression.
That's an amazing tips right there. Which kind of bring me into how is that process? Like if I am a patient who has lymphedema and I want to come to you guys' clinic, what is the whole process? Who do I see you first? You want to kind of guide us a little bit or like walk through what is the process of that?
Yeah, sure. So we're truly a multidisciplinary and multi-specialty team. Dr. Drew Singhal runs it through the lymphatic surgical team, but he'll surgery level, but he'll be the first to say that it's all about the team, and I couldn't agree more. So generally, patients, if they would like to be seen and evaluated in our clinic, and they're coming from outside kind of the Metro Boston area, if they're in the area, we just kind of see them in clinic like a regular clinic visit and check them out because they're local. If you're coming from a distance, we try to coordinate as much as we can what we think is most appropriate, so you get kind of your money's worth for the travel. So if a patient wants to be seen, we ask them to fill out a questionnaire so we get a sense of their other health issues, what their prior history was. Is it secondary lymphedema? Is it primary lymphedema? Is it in the setting of obesity? What have they tried before? What are their goals? And really try to get a flavor for what's going on as much as we can by a questionnaire. Obviously, nothing will beat an exam in history. And then we'll gauge from that review of the questionnaire, are they an appropriate surgical candidate? Are they not? Should we get imaging? Have they already had imaging? And kind of tease through. But if a patient's coming in kind of fresh, say, for example, a straight breast cancer-related lymphedema, which tend to be the most straightforward, as I mentioned, they'll come and they'll have an appointment with myself or Betsy, our nurse practitioner, to just kind of go over what they've been dealing with, what they've been doing, what their goals are. They'll see one of our lymphatic therapists for baseline measurements, see if they've been optimized, any tweaks can be made to their current conservative therapy. And then if they're coming, which most are, if they're coming from a distance or looking into potential surgical options, they'll also get an array of imaging, which we'll do. So this is like a several day process. They'll see myself or Betsy, and then they'll get imaging the next day, and then see Dr. Singhal the day after. And the imaging includes an MRI to look for the degree of fat deposition versus fluid in determining what is a main driver of the increased limb girth, like I was discussing before. We'll do a nuclear lymphoscintigram, which involves an assessment of the kind of the global function of the lymphatics in the limb compared to the other limb. And then a ICG lymphangiogram, and that gives us more of a detailed anatomy of the superficial lymphatics. And it's with the clinical assessment, the therapy assessment, and those complementary image modalities that we can sit down as a group. We have a once weekly meeting where all the radiologists are there, the therapist, Dr. Singhal, myself, Betsy, etc. And we will review the case and the imaging together and decide on what we think would be a reasonable surgical approach if the patient wants to go in that direction. And we certainly don't push surgery. It's not right for everybody. Only a minority, 10% or so of the patients that we see in lymphatic medicine ultimately go to surgery.
Okay.
And there are some patients that are excellent candidates and others it's just not right for. So we really, our goal is not to do the most surgery. It's to do the surgery on the patients that are most likely to benefit, and if it's within their goals of care and trying to improve quality of life. So we can try to hone it down to a 3 or 4 day visit, and then they leave with at least the knowledge of a good assessment of their lymphatics and what the potential options are, and then would come back at a later point for the surgery if that's something they're interested in. And we have a fair amount of patients that come and they say, well, that sounds great, thanks for looking at it, but it's just not right for me right now. And we're happy to follow those patients in the lymphatic medicine clinic, and we just check in once a year as needed based on how they're doing.
Okay. What is the role of an MRI? Like, do you guys do MRI with everyone? Do you do it with certain people?
Yeah, it's a good question. So if a patient is interested in undergoing surgery, it's part of the pre-surgical protocol. For patients that are coming in and they have a clear, like I said, breast cancer-related lymphedema, the diagnosis is not really in question, it all fits with that. We generally won't do one if they're not surgical candidates because it's not going to add much to the conservative therapy. It can be very helpful in patients that we're not sure really what's going on. I mean, they have the sensation of swelling, but we're not really appreciating it on an exam, or they have it in a unique location, like in their torso or their abdomen or their breast. They're like, I'm not really sure what's going on clinically. The MRI can be very helpful to evaluate, is there actual edema present? Because you can't really have lymphedema without the edema component. You can have lymphatic dysfunction, but to have symptoms and changes in size, and you really should have some degree of edema. So the MRI is a pretty sensitive way to evaluate that. So it can be helpful to kind of rule in or rule out lymphedema. From a pre-surgical perspective, like I said, it really helps guide how much of the increased growth of the limb is due to fat. And then if it is predominantly fat, often we recommend a liposuction procedure for those patients, because no matter what we do from a conservative management standpoint or trying to improve lymphatic flow with a lymphatic specific surgery, that limb girth is only going to decrease in size so much because that fat is going to be left over. So if for most patients, the goal is to decrease the size of the limb to some degree, others it's to get out of compression, but to get the limb girth down, debulking with liposuction is often the recommendation. The MRI is really important for that.
Okay, great. So pretty much when you do, and I'm just trying to understand because not every institution does an MRI with everything. Actually,
Sure.
I think that you guys start doing that talking with Dr. Singhal, start doing that. Like when he was here at UF, we never did an MRI here. So I think that, has been evolutioning like big time, right? He's like growing the program so great. But so if you will see that lymphatic, like that fat component versus the fluid component based on the lymphoscintigraphy or based on the ICG or both, to kind of help you to, if it's somebody who wants surgery, you kind of look at that first before you say, okay, now let's do an MRI to confirm this is what's happening.
So usually we can tell on exam to some degree, we're not perfect by exam, but if we see someone that has, for example, a 20% increased girth in their right arm compared to their unaffected left arm, but we, push in on the limb and we examine the limb and we just don't maybe a little bit of fullness, but not a lot of pitting edema. We suspect that a lot of the increased girth is actually adipose tissue, and the same can be done for the leg. So we have often a clinical suspicion. That said, we've been surprised, and exams are only so good. So anyone that's going to undergo surgery will get the MRI as part of that protocol, because again, our exams are only so good. And sometimes we see and we say, all right, there's really not that much fat. It is mostly fluid, and liposuction would not be appropriate here because there's not that much fat to remove. But it's become standard because it's common in so many patients that if we don't get it, we would, I think, be missing some important cases.
Okay, got you. Perfect. So how about the most painful lesson that you have learned through this journey?
Yeah, also a good question. I think it's, important to listen to patients, and many patients, almost all patients, know their body very well, and certainly know them better than the physician they're seeing. So I think just I've learned to, as I've gotten more experience, particularly with lymphedema patients, is to really listen to what is bothering them and not getting focused on what we think should be bothering them, but what is bothering them, and trying to improve their quality of life. Fortunately and unfortunately, lymphedema is a chronic disease, but does not generally lead to medical complexities that, decrease longevity or involve multiple hospitalizations. Certainly, there are a handful of patients that will get frequent cellulitis, and that can be medically important. But it's really the focus on quality of life. So I think early on, I was focused more on, making the diagnosis and getting the edema down. But I think I would hear back from patients say, well, I'm not really bothered by it, or I want this part surgery, but not this surgery. And even if it's not our usual algorithm, if that's what that patient wants, that's really what we need to be focused on. So, I've learned to skew away from like, you really need to be in this compression too. Let's get you in the compression that you're wearing the most, that you're comfortable with, and that it improves your quality of life, not necessarily, makes the numbers look great when we see you again in 6 months, but you're miserable because the compression is so difficult. So we certainly don't want the treatment to be worse than the disease itself. And so I think, maybe that doesn't exactly answer your question. I can't say it was a hard lesson all in one, but something that's evolved as I've gotten more experience with the lymphatic patients.
Okay. Is anything that you have that will be of value for the audience?
I'm sorry, one more time.
Yeah, it is anything that you have that will be a good value for our audience that you
I think,
share?
those tips I was discussing before, I think, again, not focused on enough, and as a cardiologist as well, and just a general vascular patient, I think obesity is such a driver for so many of the illnesses. It's an end result of the illnesses. It may not be the primary cause, but it makes every illness so much more tricky to deal with. And it's certainly, a big problem in the US as it is becoming around the world, but it decreases mobility and activity and leads to increased strain on the heart, on the vessels. And I think that combination of decreased mobility and extra pressure on the heart and vessels just has a horrible combination over years and years and years that makes, like I said, every disease just a little bit worse than it would have been otherwise, even if it's not the primary driver of the disease. I think we're meant to be active beings and being out and about. We're not meant to, which most of us do, sit in a chair for 8 to 10 hours a day and eat whenever we want, not just when we're hungry. And I think that has led to a lot of, if not focal disease, but just a general poor health. So I think that lymphedema is certainly not, immune to that, and obesity plays a significant role, as I mentioned. So I think just general activity is so important for all our patients.
Do you happen to manage anybody, like, I know you're a vascular physician as well. Do you do anything with like patients that have this heavy, chemo medications that can be so cardiotoxic? Do you manage any of these patients? And what are your thoughts on when we have a patient who is, in the red double or, adramycin, those kind of drugs, like, how hard to push that into, like, if we exercise in somebody, like, what will be the limitations with some of these patients? What are your thoughts on that?
Yeah, it's a good question. And oncology has, I think, in a positive way, become increasingly complex because there's so many new treatments that are constantly coming out, and I'll say it's difficult for us to keep up with it. Often we'll discuss a patient in conference and they'll be on this medication. We'll all say, "Oh, we haven't heard of that one yet," so I'll have to look it up. And unfortunately, though we have more medicines, which is great because they're improving outcomes for oncology, they do have side effects, and we're learning more from a vascular side and a cardiology side what those side effects are. And sometimes they just kind of come up even after the trial and not something that's been well described. From a heart perspective, because the complications are they're not common, but not infrequent, there is a whole new specialty that's really grown over the last decade called cardio-oncology. So we have particular cardiologists that's their primary specialty, is to evaluate complications in the setting of cancer treatment. And we do see the side effects of these medications from a vascular perspective as well. So really defer to my cardiology colleagues if they have, for example, new heart failure in the setting or inflammation of the heart. But we'll see patients that they have inflammation of the blood vessels or have new lack of blood flow to the blood vessels or new blood clots that can be associated with these medications. And so unfortunately, we don't, obviously haven't found the magic bullet that helps treat cancer without side effects, though they are pretty remarkable what they've done so far.
And if you find those conditions, what are your thinking about exercise? Like how much to exercise these patients? Should we back off? Should we just really push them? Of course, monitor vitals and make sure that they're doing okay.
Yeah. If it's primarily a cardiac process, it depends a little bit on, was it inflammation or was it reduced function of the heart? So there are some medications that cause reduced function from a variety of different mechanisms, but not frank inflammation. And as those patients stabilize, and obviously not an active heart failure, exercise in cardiac rehab is generally very good for those patients to keep them moving and conditioned. In the context of patients that have new inflammation, generally, though, again, we're still learning a lot about these specific types of what's called myocarditis. We generally don't recommend significant exercise because that may increase the inflammation levels or lead to heart rhythm problems in the short term. So it's very soon after. But as they get a couple of months, 3 months out, often doing a stress test that looks good, they can start getting back into exercise. So it remains a very important component of the therapy, but it has to kind of be guided a little bit by how significant their inflammation is and what their heart function is.
Okay, that's great. How can people find you?
So I am not on social media intentionally. And only have so much connection to the world that I'm already overwhelmed with by email and work and phone, etc. So I'm not on social media, but our website, you just Google the Boston Lymphatic Center or BIDMC Lymphatic Center, and that gets us connected with our webpage. And on there, we have an 800 number. I think it's an 833 number and an email to our great administrative crew to, if you'd like to be seen, you can certainly ping us. And like we said, have you go through a questionnaire and make sure you're not wasting your time by coming up, because we certainly don't want people traveling and not getting anything out of our visits. So we want them to be fruitful for sure.
Okay, great. And I will put that information on the show notes so people will know. It's easy for them to see that. How about a book that you would recommend for the audience?
So I try when I read books to try to not read medicine, because I primarily read medicine, throughout the day and most nights. But the few times I do get to read it, the last book I read was called Team of Rivals by Doris Goodwin Kearns. It's a little dense at times, but it goes through, it's really a biography of Abraham Lincoln and how he assembled his cabinet. And I think there's a lot to learn, though it's very dense in terms of its history. But I think it's very applicable to just life, and really no matter what job or career or family you have. He assembled his cabinet, hence the title Team of Rivals, were all the other candidates that had run for president and lost. But though he did not agree with all of them, and some were political adversaries, he felt they were the best people to do the job. And I think we probably don't do that enough in real life, and to accept our differences and work through the differences we have and compromise, but identify the strengths that are more often, greater than our differences, and how to work together for the better good of whatever we may be doing. And I think that's very applicable to a lot of parts of life. So it's again, a little dense, long, dry at times, but you get a lot of detail, maybe more than you want. But I think the overall message is a good one.
Excellent. How about any podcast?
So similar to when I try not to read medical, when I'm stuck in the car for too long, a podcast that I have enjoyed is called Conan Needs a Friend. So it's Conan O'Brien, and some people, his comedy is not for them. But it's a podcast with Conan O'Brien, who used to do a variety of late night shows, but he does a subset of his podcasts are not celebrities. They're just regular people. And so I think it's interesting. You hear a lot of from people around the world that have different careers, and it's light and it's funny. But it's also just a nice way to hear about how other people live. So it's again light, but it's a insight into the world where we may not get otherwise.
That's great. How about movies?
So movies, I to be honest, I haven't seen a movie in a long time that wasn't an animated movie for my
Yes.
children. So I really like Ferdinand, which is about Ferdinand the Bull. It's a kid's movie. It's a few years old now, but it's just a good story and lighthearted, and so that's my go-to child movie. I don't have a good adult movie that's anything recent.
Yeah, again, hopefully after the kids grow up, then you
Yeah,
can
I can get back into
adult
watching a real
movies.
movie.
Is any one question you wish I will have asked you and will you have answered to wrap up?
No, I think we hit on the main components of lymphatic therapy and overall health. I think just because the podcast is for all oncologic patients, I think that we focus really on exercise and weight for lymphedema patients. I think it's true for really any illness, and we see it a lot. I take care of a lot of patients in the hospital as well, and we as humans decondition much more quickly than we condition. So as much as you can, and obviously if you're very sick and you're feeling horrible, it's difficult to do, but as much as you can get up and move and stay active, and that's going to be different for different people. So for those that are very active and unfortunately get sick quickly, going for continue to walk, or taking light jogs or doing light weightlifting, and then for older frail patients, maybe just continuing to go grocery shopping and little things. But I think the more we slow down, the harder it is to get back there. So again, obviously unfortunately some patients get very sick and they can't do those things, but trying to stay active and conditioned in just mild ways, I think is important regardless of the illness.
Yeah, that's excellent way to wrap up. That's exactly what we keep telling patients. We have in the oncological world, we see patients with stage 4 and the cancer, and then we really try to tell them, it's not about the cancer, and if you have a pet and it's a new spot showing, it's about quality of life, right? So it's like, how are you feeling? Are you feeling that you're having any issues? Are you having any problems doing what you're doing? Actually, after we work with them, they feel so much better. They feel better than before they have their cancer diagnosed. So many times I tell them, just focus on that, focusing how you feel, even if your patient a new spot on your liver. That's okay. I mean, the medical oncologists will treat that. They'll figure out chemo. We'll figure out, secondary effects, and we try to help you through that. But try to focus on your quality of life. You're able to play with your kids. You're able to play with your grandkids. You just went traveling and did hikes. So that's really what it's all about, right? So sometimes we tend to focus so much on the disease that put us down versus like, okay, yes, I have this disease. It sucks, and I have to do these treatments that bring some other things, but how you feel right now? Are you able to continue working in where you were doing? Are you able to continue, golfing or riding horses, or as simple as, like you say, grocery shopping? So everything goes back down into quality of life. And the more you move, the better, right? No matter why you have any vascular, any cardio, any cancer, just that's the best thing to do. So yeah, always encourage them to do that. Well, Dr. Carroll, has been a pleasure to have you. I learned a lot. Love this information. Like I say, I wish we have somebody like you here. I'm more likely going to start to, when I release your podcast, start to share that with our physicians, and they're like, come on, we really need to get this moving towards that direction when we can have a good, physician, either vascular, to try to really help with this lymphedema diagnosis. I think will be really helpful. But thank you again, and I really appreciate your time.
No, thank you so much for having me. It was fun. Thanks.
Okay, sure. Have a good evening.
You too.